of this place, this huge great work area, and there was all Olaf's equipment all the way around the wall. So one day I got kind of a little bit excited because I knew he was going to work out, so I got my tracksuit on and I went in there. I see him working on this equipment, so I started sort of going up, and I'm having a bit of a struggle. I get to this one thing which was a kind of like a leg press machine, so I get on there, I get myself set up, and I'd just seen him on this thing. I pushed down like mad and nothing happened, so I pushed again, so I got off. I thought, oh, this is locked, and I go around and it wasn't locked. Olaf had been sort of like pushing something like 550 pounds and he's 66 or 65 years of age. That's an incredible fitness. Then I go on my daily walk and I see him there in the park, and he's throwing this discus, you know, just beautiful. Just incredible. Okay, so let's do the extension, the flexion, the rotation in this position, and we'll kind of leave the side bend to those that are strong enough. And for the weak ones like us, we can do it in sitting, and it's nice in sitting, so why let's struggle. Okay?
Thanks.
Straight into a review of this morning from the point of view of using the techniques once we've found a problem, of using a similar technique to correct the problem. Now, not always can we extrapolate the treatment procedure into, or the examination procedure into the treatment field, but very often we can, and that is nice. Now, the first thing that we should look at is the application of compression and the application of distraction. These are both assessment procedures, and the distraction, of course, is a treatment procedure. So rather than me putting all these up on here, which I'll do just to remind me what to show you, and I've got several kind of treatment plans, and I don't think any are any more valuable than any others. It's pretty obvious that we can do treatment in sitting or treatment in lying, prone lying, supine lying, and prone lying. Now, as far as the prone lying is concerned, just before we start, let me just show you a little picture, which is kind of an interesting little plan, and illustrates a lot of things that people do with the thoracic spine. This is two thoracic vertebrae looking from the back and imagining that the patient is lying on the stomach. So that what we're going to look at here is what happens if we actually provide contacts here and move the other bone. Now, first of all, if I provide a contact at the transverse process of the caudal bone of a segment, I can then do a whole variety of things. I can distract that upper bone away from these. Okay? I can, in actual fact, think in terms of perhaps the supine position, and I can hold and do distraction and so on. But if I'm looking at rotation, which is what I'd like to just talk at for a moment, if I press down on this bone here and contact that bone there so that I'm doing that motion there, automatically I produce a rotation. And if I produce a rotation, what is happening at the zygapophyseal joint? It gaps. Which side gaps? The left side. So that we're always going to gap. We rotate in the direction of the lowest contact point here. So the patient could lie on in the prone position, and I could sort of engage these transverse processes and push down like that. Or I could go into the supine position and still contact asymmetrical points like this, and by just going in a straightforward posterior glide, because I'm providing an asymmetric point, it will rotate the bone. And of course, rotation produces gapping of the zygapophyseal joint. And if that is lost its movement, this is a very desirable thing to do. What's the problem with gapping a zygapophyseal joint?
Narrow the
You narrow the foramen. So what we'd better know is that there isn't a disc problem in that region. And that's a sort of similar thing that we have in our minds for all areas of the spine, isn't it? Now, the prone position for me is not a particularly good position. I never ever use it. What are the ease of using this position here? For examination, it's fine. I'm talking about for treatment procedures when we're trying to produce movement of bone. For soft tissue techniques, no problem. But when we come to doing techniques of mobility, it's kind of easy to apply pressures. But what we've got is the ribs are being contacted with the bed, so that we're basically blocking rib motion. And ribs are vulnerable, particularly if we're starting to deal with osteoporosis that might be incipient. And remember that osteoporosis, to reach a level that we see on X-ray, you've lost 40% of the bone mass. So it's not like an early change is seen immediately on X-rays. And so I think when we look at the prone position, it's restricted in its use as a disadvantage. Secondly, lots of other people use it, like chiropractors, and it might be good if we got a totally different approach to patients, okay, to this sort of thing. It's extremely not very versatile, because all I can virtually do is to do a straightforward pressure, but I cannot take into consideration the curve of the spine very much at all. If I use all the same principles as on the board here, and I use it in the supine position, although it's more difficult to understand the principles, I have got so much more versatility. For example, if I use a symmetrical contact point on two transverse processes here, I can do a distraction technique. If I use the same two contact points here and do an posterior glide, an anterior posterior glide, I'm going to get a bilateral gapping of the facets, which will aid extension. If I take a unilateral contact point and still go down directly antero-posterior, I produce a unilateral gapping. And equally well, I can use the principles that we spoke of this morning in the supine position, so that I can use the coupled movements to produce rotation in a soft end feel, so that I'm not stressing very tight and very rigid rib cage. Or if I've got movement that is a little excessive above and a stiff one below, then what I can do is I can use the non-physiological locking positions. So I would suggest, although it's more difficult to pick up the principles, the techniques of supine position are so good that we should make that our own and really establish that that is the way that we do this. But just occasionally to go back into prone is okay, because it might be very difficult for some reason, you know, the patient's too big or something like this. But I would suggest that we really do try and develop the supine techniques rather than the prone techniques, and that's what I would like to concentrate on, as well as, you know, some of the other things this afternoon. So let's go straight over to the tables. And let's start where we left off this morning, so that you know, we're going from known to unknown. Good teaching principle. Can you lay on your side?
Yep.
And where's your shirt?
On the floor over there.
Let's just put this down so you're not sticking on the table. Okay, here we go. Now, this is when those techniques of you using your body really come into their own. All right? Because we can translate our rock in a very positive way to a person's spine. Now, if you look at the kinds of motion that in general we'll be trying to restore, of all of the movements, basically extension and rotation are going to be where we probably put the greatest amount of our effort. Especially extension, because these patients get stiffer and stiffer forward. And so we've got to try and allow them to go into a unflexed position and get more into an extended position. So the one that we did this morning, can you put your hands around your neck? I'd like you to do it now from the point of view of how can I use this really now as a mobilization. So I found the level here, okay, and I'm going to take a fairly firm grip on here now, and I'm going to work into this now like this. All right, now what I want you to do is to think to yourself, what is the end feel, and can I make this patient do some of the muscle-based techniques? Can I do some of the just passive movement techniques, depending upon what the end feel is, okay? Can you take it back just a bit there? Yeah, that's good. And again yourself, go on. And again yourself. So that we can actually start using the, okay, now relax, now let me work it, the appropriate motion for what we feel is the barrier. Now then, being as you asked me that very difficult question that ruined my lunch, thinking about what the answer was today, what do you reckon is stopping extension of the spine if it's muscular? Everybody can answer it. What are these muscles that stop extension of the spine? You know, in muscle energy we talk about the bone, you know, the when we've got flexed lesions, something's holding it flexed. What are they? I don't know. But there's something, and when I say just hold there, stop me going back, he holds, he uses his arms a bit, he uses his abdominals a much, but are there any sort of more intrinsic to this level? He's using the intercostals probably too. Now relax, now pull back a little yourself. So we can actually do a very good movement. This is just an excellent technique. I nearly always do the extension movement in side lying. I always impress myself no end with this particular thing. You can stand upright, you can do the movement, it feels good, you can have a lot of control over all of the factors like the muscle, the joint, and so on. So that is a very easy technique to sort of do. I'd also like you to practice a little bit the rotational techniques. And the one that we did this morning is also extremely useful. First of all, it's useful to come into the upper part with the hand over here. Now, we need to, when we're doing mobilizing, we need to definitely sort of hold and stabilize better because we're doing it for a longer period of time than when we're doing testing. It's more stressful. And we're probably doing it through joints that are moving normally, and we've got to try and bring the forces into the joints that are not moving normally. And so I can come into a position here, and I'm going to sort of try and provide a block at this joint here, let us say. And I've decided that that's it. So I'm going to do my movement here of up and up and up until I find that I've got the forces exactly right over that T5-6 there. And now I can sort of move back over that joint there using my whole forearm on his hand and forearm there. And you see now I go back to my kind of body rock. I'm using my body here, but this arm is like not part of me almost, it's just acting as a strut. It's this hand and my body that are moving, this one stays still, and I'm using the block on the side of the bed here to make sure that he doesn't move through this joint that I'm trying to mobilize. That's going to want to rotate to the next joint down. I stop it rotating. Once again, I can try. Okay, can you stop me going back? Great, not quite as much as that, a bit more discreet. Now relax. Now right over my thumb here, can you pull back? And I can do that and make him move in that way. And so extension and rotation in side lying are excellent techniques. Now I'd also like you to go down to the lower part of the rib cage here. And we spoke about this position, but I'd like you to really bother about it now, which is to use a contact with your forearm and hand like this around the rib cage, so that when you come down to the bottom here, you actually move the rib cage using your body, using this all in there, and sort of rock yourself like this, so that you can produce an excellent non-stressful movement, which if you went from the top would be bringing in the whole of this lever, and this seems to be pointless. So let's just go in and do those movements there like that. So just to start the afternoon's proceedings, we will do, this is rotation to the left. We're always rotating to whichever side is on top, aren't we, in these standard motions when we take the shoulder back. And we know under those circumstances that the joints on the top side here, on the left side, are the ones that are going to be gapping. And on the other side they will be impacting to some extent. Okay? So let's do those now with the difference between when we did it rather more discreetly for the test. Now we've got to make sure that the stiff joints move. So that's the start of the afternoon. Okay, off we go. Make a contact at whatever the lower, the caudal bone is of the segment that I'm trying to move. And I've tried this with wedges and pillows and all kinds of things here, so that I can come in here, hold the position here, and then just lift with an attempt to do a distraction like that. So I'm lifting here, and if distraction is a movement that seems to assist the pain, then it's one of the very safe maneuvers. We kind of feel it's the safest thing that we can do. Just as a little aside here, because we can use this, and we didn't use it actually when we were doing the last of our examination procedures, should be to say, what is the effect of distraction? What is the effect of compression? Now, when we use the distraction, we try and get it as local as possible, but as with most traction, it's only a semi-specific technique. With compression, a lot of the times compression is done through the shoulders here. I've been trying much more lately to just, can you put your hands down, to go a little bit closer to where I think the joint is and push down there, rather than bring all these joints in the compression to get down to this particular affected segment. And I think that I've produced a little bit less or more specific distraction, compression doing this. So in coming in here, I can do a very kind of local compression as a test, and I can do a semi-specific distraction in sitting, coming in here and lifting like this. But I don't like this particularly. What I like very much is that technique that we did yesterday for the cervicothoracic junction, which is the one where we lay the patient in supine. Now, what I'd like to just emphasize again and again and again is that what is so important with the thoracic spine is remembering that it is essentially a kyphosed spine, and that when we deal with the kyphosis, that is its neutral position, and we should be doing these techniques by accommodating the kyphosis. We shouldn't be allowing the patient to go into extension over our hands. With your partners here, you could gently try it, and it's diabolical. And I look at books and I see patient back over somebody's fist, and I wonder, is that how they do it, or was it just a careless photograph? It makes a difference. And if we're dealing with osteoporosis or anything like that, when we sort of do these very definitive techniques of mobilizing and we accommodate the curve in the spine, I think you'll get into very little problem. And I do it on my 80-year-old ladies. I give them a hug. you know, and just move like this, and I've never had a problem. But I think the prone techniques and all the other techniques to try to increase motion, because they tend to force extension, and supine will force extension if you're not careful, this is a problem. So let us start at about T4, and then you can take some point further down the spine just to get how much more difficult it becomes the lower you get. So I would gently roll the patient into me. I lean on them like this and I roll them so they don't think they're going to fall off the table, suddenly fling their arms apart and pull you over the table. So if you sort of lay on and just come over like this. Now, in this position, I would just suggest this, that it's quite a good thing. You can do a little extension motion or a little rotation motion just to clarify that you're on the exact spot that you've picked up. You've made a little mark like this and it's disappeared by the time you get into this position. You meant to get a ball pen mark, but you hadn't got a pen in your pocket. So you made a little mark with your finger like this, and it was perfectly clear when you got them onto the back. Now you can't see it. Okay, you all do this, all right? So now we have to sort of clarify, and this is not a bad position for just doing that, just coming around and clarifying that we're on the correct bone. Okay, now then, if I want to fix the thoracic vertebra, I'm going to go on to the transverse process. And what's the relationship of the transverse process to the spinous process? Because I'm feeling between the spinous, aren't I? Where is the transverse in relationship to the tip of the spinous process? How far above it? Varies with the segment. Go on.
Higher and lower, it's maybe about one segment above, and in the middle it can be as many as 2 or
3 of the patient's fingertips. Okay, so you kind of look at their fingers in relationships to yours and try and just judge that. So between about 3, 4 and the equivalent ones down below, we've got 2 spaces. Then in the middle series here, we've got 3 spaces. All right, and then right at the top we've got 1 space. So let us take a 2-space one here. We'll go for T4, T5. So I come into here like this, and I'm coming up to T4 like that. So I find where the tip of T4 is. I look at his fingers, which are about as thick as mine, so I come from here with my 2 finger spaces and I engage the spinous process, which means now that I'm going to try and go back over my hand, but to accommodate that curve. So here I am. I come into here, I thread round, and I just lean him over like that, so that the spine is in its flexed position. Now I can give the distraction motion very accurately here. I can use that grip, I can put my wedge in position, and use that to give a much more specific distraction than with them in sitting, in my estimation. Now, let's go back. I lay him down and I take a lower level. Let us come to C6, 7, and we'll take the 3 space here. So come onto the tip, look at that, get onto the spinous processes. Now I'm going to have a little more problem because I'm going to have to lift him a little up. So I roll into that, I accommodate that curve, so that's where he should be now. Now I can do my distraction in that position there. Now, he's a good guy, this, so he's going to sort of stand this, and I'm going to be a bit careless, and I'm going to go into there. What would you say?
Uncomfortable.
And if I come into here, and I'm going to press a lot harder. What would you say?
Better on the back. I'm getting choked up here.
Okay, okay. There.
Okay. Yeah.
Okay. So I can pull and I can distract there quite strongly, whereas if I just gently let him go of my hand here, it becomes more and more painful. So make sure that you accommodate that curve. Now, the lower down you get, the more difficult it becomes. However, when you've all got your super tables, you just have a table here and you lift it a little. No big deal. So we just lift it here. Okay. I now lift the table and I would side bend him a little because I've got the table lifted up. Now when I roll him over like this, the table is taking most of the weight because it's kind of coming up in this position. So I can put my hands in here and just slide up the table now. And so the lower I get, I can use things like just the lifting part of the upper part of the table, the head end of the table, just to support this so I don't have to do a tremendous amount of support. And so in this area here, we've got the possibilities of doing a sitting traction. We've got the possibilities of doing supine lying traction, which is what I like. Or we've got the possibilities of doing, in the upper part anyway, I hope I don't make a right mess of this because I haven't used it for some time, but I know a lot of people that use it all the time. Can you just put your hands up behind your neck here? I want to sort of come down here again. And you come into this position here, into that position there, and then I can stretch like that, using my body, as you see, coming up like this. And if I want to get my hands right the way around, I can put them right on the level, just underneath this belt. And this is kind of nice, just to pull there. Would you say that's kind of quite reasonable? Yeah. And this is not so hard on you. And so for the women working with perhaps a man that's a bit heavier, perhaps this would be a good thing to use here. And once again, if the table, it's a bit lower, I would lift the end of the table up here. So he's kind of in this position. I'd bring the table down towards the ground so I'm not killing myself, and I would just be pulling now at this angle along that curve. So there's a lot of ways of applying traction, from the sitting, which is only semi-specific, to the lying one here, which is very specific, to this one, which is also fairly specific. And I think it just depends upon the size of the patient and whether you have tables and belts, of course, available, as to which one you use. But I think that the one in supine has a lot to say for it if you're my size and we're working with people that are smaller. If you're smaller, then it's going to be harder work for you, no question. The wedge is a modification, the belt is a modification of that particular set of techniques. So they're very good techniques to do, no question. Would you try the distraction techniques?
Could you demonstrate the sitting one again?
Lay on your back a second. Head at this end. Okay. Now, just one or two things for this supine technique for distraction, rotation, and posterior glide. Obviously, this is an extremely important technique. It's also the technique for manipulation, and it's also the technique that we're going to be superimposing some of the coupled and the combined movements on top of. So we kind of need to understand this. Let me just tell you a couple of points. If you're standing next to the patient, make sure that the arm that is the nearest you goes nearest to the patient. So you've got that, like that. That means that when you come over here, you're not forcing the patient's forearm when you're getting this contact into the patient's ribs. And equally well, if we're going to work on this side, it means that if I want to produce rib movements, because this is going to be another technique, just by changing our contact points we'll work the rib, I've not got any kind of restriction here or here for rib movement forward. So that's quite important. Now, as far as your hand